Well, I tell you what, I'm going to pass Idebenone to a man who's done both of these men have done a great deal with it. But before I get to that, we can talk about, has there been any proven benefit to a specific agent? And that's been tried. Vitamin C has been tried, vitamin E has been tried, and coenzyme Q has been tried. I think that they've been tried enough that we can say that, per se, they don't work, which is a particular disappointment with coenzyme Q10, because for the reasons that Valeria alluded to, it would make sense. And I think the conclusion was made some 25 years ago that vitamin Q10 is the right agent, but you can't get it in. So you can take all you want by mouth. It doesn't get into the mitochondria, so it doesn't really solve the problem. And so a version of coenzyme Q10 was developed in Japan, and it's called Idebenone. It's a version that has the better drug delivery capability of getting in. And with that, I'll turn it over to you.
Yeah, I'll give you a historical perspective, and then I will pass the microphone to Patrick, because he was actually part of the clinical trial with the pharmaceutical company promoting this. So the historical perspective is that Idebenone was commercialized in Italy, so it was approved for being used in patients, and this is not true for other countries, for example, in the United States, for dementia. So any kind of cognitive impairment, degeneration, and so on was told that could be treated with Idebenone as a neuroprotectant. And in early 90s, I guess was 92 or so, 94, whatever.
Around that time, the Mashima study.
A doctor in Japan, Mashima, actually gave Idebenone because it's a similar molecule to coenzyme Q, but apparently with better distribution, better potency, gets into the mitochondria in a more efficient way. So he gave Idebenone to a patient with labors, and he published this little letter saying that the patient actually recovered quite a lot of vision. So because Idebenone was legally commercialized in Italy, we started giving Idebenone, and we also did study some of the biochemistry in vitro of Idebenone with cells. And so in Italy, has been possible to give Idebenone legally with no problems to patients. Then, at some point, a legislation came up in Italy protecting people with rare disorders. So each, under a specific certificate for diagnosis of a rare disorder, each patient has access for free to Idebenone. So this is being covered by the state. And at that point, we definitely started to administer Idebenone in a very systematic way to each single patient. So our patients' population, after a certain year ahead, they all have been given Idebenone as a therapy. So what we did at some point in conjunction with the clinical trial, and in a bit I will pass the mic to Patrick, is that we looked back at our patients after this certain year. We started giving Idebenone to everybody, and we compared the natural history of the patients treated with Idebenone with the natural history of the patients, of the relatives of these patients, which did not have Idebenone treatment. And on the very, I mean, the points, the two main points that the two main conclusions we had is that you have to give Idebenone for a long time, earlier is better, and in particular, the statistics was particularly solid with 11778. We raised the recovery, the rate of recovery from 20%, as I was mentioning before, spontaneous recovery, up to 40 or so. So what we see with Idebenone in our experience is that we never been able to stop the progression of the disease during the acute phase, not not in a clear way, maybe we can preserve some fibers during the acute phase, but it's a matter of fact that the patient would lose vision anyways. But what happens is you increase the capability, the probability of actually recovering vision later. And this is probably related to the fact that you are sparing more fibers during the degenerative process. If you have more fibers, even if they don't work, at some point you can reverse the process and make them work, and so then you recover a little bit of vision.
And just so there's no misunderstanding, by recovery he doesn't mean full recovery. He means some modest improvement.
Some improvements, yeah. So,
I think it's been very helpful, Valerio, giving the historical backdrop, because as Alfredo mentioned, it all started with coenzyme Q10, which made a lot of sense, but one of the big reasons why it's probably not working is because it's quite a big molecule. It does not cross the blood-brain barrier very well and doesn't penetrate the mitochondria to provide its function. So now we have Idebenone. Alfredo is very lucky, Valerio is very lucky because in Italy he's been able to provide Idebenone to his patients, covered by the National Health Service, but we don't have this opportunity in the UK. So about 6 years ago now, with my colleague Patrick Chinnery, who is a professor of neurology in Newcastle, we got involved with Santhera, the company based in Basel, who basically provided the resources to do a randomized control trial for Idebenone. So it compared two groups of patients, patients with labors and who had the active medication. The dose of Idebenone that was used was 900 milligrams, so 300 milligrams 3 times a day, and that was compared against placebo. So people were taking dummy tablets, but they did not know whether they were on the active or inactive compound. The study was relatively short. The study was for 6 months because obviously there's a cost attached to doing any trial. And when the results were analyzed, the main outcome measure was negative. But then when we did a subgroup analysis, there was a group of patients who had earlier duration of the disease process who seemed to be doing better. And as Alfredo mentioned, we're not talking here about a dramatic recovery or reversal of vision, but statistically, if you compare the group that was treated with the group that wasn't treated, they did better. And again, our study was slightly undermined by the fact that it also included patients with a 14484 mutation, where there's a better visual prognosis. And as Valerio mentioned, the treatment effect was much more obvious when we did the subgroup of patients with the 11, 7, and 8 mutation. So what did we find after doing this randomized control? First of all, it's safe. There were no major side effects. It would be advisable if someone takes Idebenone after 6 months to have their liver function checked, just to make sure there's no disturbance there. And based on the promising results from the subgroup analysis, Santhera then went to CHMP and EMA, which is the version of FDA here in the US, to get approval for Idebenone for patients with Leber's optic neuropathy. So 2 years ago, they got the decision that EMA said no, because they felt there was not enough evidence based on the amount of patients that were treated and where the treatment effect was found. So that left us in a very difficult situation in the UK because patients obviously knew about Idebenone, wanted to get access to it, but we could not prescribe it. In the meantime, Santhera has launched a named patient program, and I don't know the final numbers, but they certainly recruited more than 60 patients into this named patient program. A lot of patients were recruited from Germany, in Munich, by Thomas Klopstock. And my understanding from what has been in the public domain is that at the moment they've submitted all the data again to the EMA, and they're expecting a result in the next few months regarding whether or not Idebenone can be prescribed to patients with Leber's optic neuropathy. So my personal feeling about Idebenone is that it's not the magic bullet. It is certainly not the best treatment out there for Leber's. We need much better treatment for this condition. It seems to be having a positive effect, but we can't predict who is going to benefit from Idebenone. The other question that we don't know is how long we need to treat, because the advantage that Valerio had is that his patients were on longer-term treatment, and when we look at your data, it seems that the longer you treat, the better the visual benefit between the treated and treated group. So I think there's a lot of unknown. My personal wish would be that whatever happens with Santhera's more recent application is that we need a bigger trial with more patients treated with a longer, for a longer duration of time, and also with higher dose of Idebenone, to clearly fully establish what is the effect of Idebenone on the natural history of Leber's optic neuropathy.
Yeah, one point to emphasize, I'll be very quick, Alfredo, is if a Leber's patient gets Idebenone and after 6 months doesn't perceive any apparent improvement or effect, it needs to keep going. This thing works on the long run. And in general, for any antioxidant approach, so I'm not talking just about Idebenone, but possibly about other antioxidants, and we may mention this. The experience is that correcting the biochemistry of Leber's takes months or maybe years. It takes a long, long time in order to make these fibers getting back to function. So if you give up too early, actually you are wasting the probability of having some good effect.
I completely agree, and I was about to make that same point, and also to tell you how I think of it. I think of it as when you have your vision loss in the affected patient, that typical patient I told you who was in his freshman year in college, you're losing all the small fibers and maybe some of the medium ones. And Idebenone probably doesn't have any benefit there. But its benefit is it keeps that advancing wave from affecting the medium-large ones and so on and so forth. So it's a good idea to have it, to keep taking it for a long time, forever. I never ask a patient to come off of it because it's working on that later phase of the advancing wave of the loss from one to the other. Also, I should mention, because my distinguished colleagues are from England and from Italy, here in the United States, we don't have a National Health Service that gives Idebenone free, but the majority of my patients go to the internet where it's quite available legally as a food supplement. It is not restricted by the FDA. And so we recommend that you actually look at several different internet sites for this, because not being FDA approved, it's a little bit less certain that they're going to stay open, so you want to make sure that you can get it and maybe stockpile it a little bit. But it has been sampled and analyzed, and at least the sites that we have been putting out there are the real thing, and they get the same Idebenone. Probably with a little bit less precision in terms of concentration, but since we don't know the exact concentration to give, I don't think that's a big deal. So if you end up getting 5% more or 5% less on the internet versus the prescribed amount, I think that's well within tolerable range.
And when patients do take this, is there anything they should do in addition to taking that?
Yes, and there's one thing they should do in subtraction. So first, the addition. Idebenone acts to prevent oxidation. And in itself, it gets oxidized in doing that. Now, some of the people here in the audience might remember, how do you prevent a cut apple from turning brown? That's getting oxidized. And the answer is you put some lemon juice on it, and then it stays nice and fresh for a day. Well, you do the same thing using, and the reason that works is that there's vitamin C in that lemon juice. You do the same thing to the person. So I don't think that vitamin C by itself is particularly useful, but it's a very good idea to give it in addition because it keeps the Idebenone in its reduced stage, in its fresh state. It's like putting that lemon juice in the apple. The flip side is there's something you should not take. We talked about how, in general, taking coenzyme Q10, if you're, say, on statins, is a very good idea, and I agree. But if you're going to be taking Idebenone, I would rather you did not take coenzyme Q10 because there's good reason to believe that the transport molecules, the mechanism by which your body pumps the Idebenone into the mitochondria is the same as putting the coenzyme Q10. And now if you put the less effective as well as the effective medication in at the same time, the body in a sense gets distracted by the ineffective one. So I think that's the one time coenzyme Q10 may actually be a mistake.
Yeah, one comment is about dosage. There is no established dosage for this therapy. The company used 900 milligrams. What we do in Italy is in acute cases, we go up to this 900 milligrams and we keep going until things are dynamic, which means until we observe some changes in visual function, we stay up. After 1 or so year, maybe 2, that nothing happens and the situation is completely stable, at that point we can also try to reduce a little bit the dosage, and usually we go down to 450, which in Italy would be, I mean, in Italy we have pills 45 milligrams, so everything is based on how many pills, and usually we do either 9 or 12 in a chronic administration. But during the acute phase, you want to go high. Some side effects, I mean, Idebenone is safe, but what we see sometimes is raising cholesterol in some people. So maybe we should take care of that, and diet at the same time as you get Idebenone would be an option before you get the statins. And sometimes in kids, in younger people, you can actually get some decrease of white blood cells, leukopenia. All these things are absolutely reversible, and they do not produce any symptom. These are just things that you see because you do the blood exams. And then we usually check that the person is able to have a normal renal and liver functions, obviously.
Yes. From the UK perspective, as people have mentioned, there is always an interrogation mark on what dose to use and how long to treat. And people in the UK who decide to go on Idebenone will get it from various internet sources, very often based in the US. And the cost is not inconsequential, especially when you add import duties and everything on top of that. And sometimes, if people don't get any benefit from it after 6 months or a year, it's a bit difficult for them to motivate themselves to carry on paying for it. So I think the cost element should not be discarded altogether.
Of course. And it should be, speaking of the economy for Idebenone, you probably do a better job absorbing it, therefore getting more bang for your buck, if you consume it with some sort of fats, because it's a fat-soluble molecule. So men don't usually need to be told to take some fats. You know, they're going to have French fries or milkshakes or hamburgers anyway. But we would explain to women that if you want to have a salad for lunch, maybe this is the time not to have it with a low-cal dressing. A little bit of fat will help the Idebenone go down.
Regarding Idebenone, what recommendation would you have for an affected patient in their 40s or 50s who has never had been taking Idebenone or had any real recovery or reversal?
Yeah, this is an extremely good question. My feeling and what I do is to make a try with any patient, because the theory here is that you have a certain amount of fibers left, and a certain subgroup of these fibers is suffering and not functioning properly. So this tiny group of fibers could actually benefit of Idebenone, even in a very long chronic patients that has had the disease for decades. I would make a try. Then after a reasonable time, let's say a couple of years, nothing happens, everything is stable, you can always drop the administration of Idebenone. But in general, I would make a try, because there is always a certain amount of fibers that could be ameliorated, rescued, protected by Idebenone administration. I don't know about you guys.
I agree, but it's always a risk versus benefit comparison, right? And so you heard me earlier saying I wouldn't give Idebenone to carriers because I think the benefit is greater in a middle-aged man who still has this wave slowly marching from small to medium large, and I'd like to stop it wherever it is.
If somebody is taking 900 milligrams of Idebenone and kind of break it up 300 throughout the day, how much vitamin C possibly should they be taking in?
Boy, that one's simple.
In concert.
500 milligrams is probably plenty.
For each time?
No, eat once a day.
Just once a day is okay?
So
okay.
let me exploit your question for one more point. We've been saying, I think, unfortunately, 900. That's not what really matters. What really matters is how often you take it. Because it's not like an antibiotic that the more you get in there, the more effect it has. If it works to change the metabolism, it works because there's no absence of it. So some people think, well, gee, if I take 300 3 times a day, it's so cumbersome, I'll just take 450 twice, or maybe 900 once. It doesn't work that way. Spread it out. On the other hand, vitamin C, if you take one 500 milligram tablet, it'll be there all day long.
Okay. All right, good. Thank you.
Yeah, I have a quick question on the Idebenone. Why is it, I've seen some people talk about they have a liver functioning test done. What is the reason behind that?
Well, this is an observation that came out from the various studies that have been done looking at Idebenone, that certainly to think about the Rhodos trial, there was only one patient where there was slightly disturbed liver functions. It was not very abnormal, it wasn't causing liver failure, but there was a suggestion that the liver function were heading the wrong direction. So it seems to be sensible as to have your blood check, certainly that's 3-6 months down the line, to make sure you're not developing any problems. There's also been these reports of your white cell count decreasing, but I must emphasize these are rare events. Generally speaking, it's quite a safe drug.
Yeah, agree.
And I guess my last question is, how did they come to 900 milligrams a day? Like, why not 2,000? How did they come to this number of 900 milligrams a day?
Definitely not makes sense.
Well, I don't have the answer. You have to ask Santerra. But for all these companies will do these pharmacokinetic studies where they will be, first of all, treating, for example, a model, whether it's a mouse or a rat, to see what dose they're getting toxicity. But, certainly, when it comes to Idebenone, up to 250, as they've used in some trials, seem to be safe. But whether or not, as we've been discussing, the dose should be 900 milligrams, should be 450 milligrams, should be 2,250 milligrams, we don't have the evidence which one is a better dose. And, you will only know that by doing another study and comparing 900 milligrams with 2,250, for example.
Yeah. There are some studies that we are doing. In reality, Idebenone is getting broken down in other molecules, and this is something that happens quite fast in the body. So one of these molecules seems to be the one more active than the others in terms of therapeutic function. So probably it's not even Idebenone itself, but some of the metabolites that are actually functioning on the long run.
But just to maybe finish with a almost jocular point, the most dramatic medication I think ever introduced that really works is penicillin. And the standard dose is 250 milligrams 4 times a day, which adds up to 1,000 milligrams, which coincidentally is 1 gram. If you think there was much more science to it than that, you'd be mistaken.